Hey, DNA. Kate Wilson here with another episode of All Access DNA. In today's episode, we are talking to Dr. Shelley Sella about her new book, Beyond Limits: Stories of Third-Trimester Abortion Care. Dr. Sella is a retired board-certified OBGYN and the first woman to openly provide third-trimester abortion care in the United States. This is her first book and is a tribute to the real people whose hearts, reasons, and stories are more complex than politicized conversations about abortion lead us to believe. Please note that we will be discussing the procedure of third trimester abortion. Our conversation talks about Dr. Sella's professional journey, patient stories, and the impact of legislation on access to needed health care. We are also giving away several copies of Dr. Sella's book, Beyond Limits, over on our Instagram. So be sure to check us out there at All Access DNA. Let's get started. Hi, Dr. Sella. Thank you for being on the show today.
Thank you for having me.
First, I wanted to ask you about your book, Beyond Limits, and I wanted to know what inspired you to write this and what you hope readers take away from the stories that you're sharing in the book.
Well, thank you. At this point, there are many books about abortion that have been written recently, but no one has ever written about third trimester abortion care. And so I thought, given my experience providing that care for almost 20 years, both in Wichita, Kansas with Dr. George Tiller and in Albuquerque, New Mexico, I thought this would be a great opportunity to help people have an understanding of this care, which is the most stigmatized and most misunderstood segment of abortion care. And my intent is to help change people's hearts and minds and to kind of give them a sense of what the procedure is like, what patients go through, why they make the decision to have a third trimester abortion. And I thought that my experiences providing this care would be a way to convey that information.
And I think it's very much needed. I can say in my time as being a prenatal genetic counselor and then talking with folks not of that sphere or that world, that was one question is like, why would somebody do something like this or have this type of procedure? And just to set the stage, when we are talking third trimester, can you tell us what weeks or what months of pregnancy that is?
Yeah, so pregnancy is divided into trimesters. The first trimester goes to 12 to 14 weeks. Second trimester is 12 to 14 to 24 to 26 weeks. And third trimester is 24, 26 weeks to term. A term pregnancy is 40 weeks plus or minus 2 weeks.
Okay, gotcha. And you had mentioned that you had worked with Dr. George Tiller. I think also in your book, you mentioned working with Dr. Susan Robinson. And we'll put some information about them both in the show notes. But how did working with them shape your philosophy and approach to abortion care?
So I came into abortion care already with an idea of how healthcare should be delivered. I had um, worked with I went to medical school intentionally to learn how to provide abortions. And where I was first exposed to abortions was at the Los Angeles Feminist Women's Health Center in the late 70s. And that was a completely different model of healthcare. It was an idea, it was connected with the feminist movement. And the idea was to empower women to take control of their healthcare. And so in that setting, the the patients, and actually we were told not to call patients, they were women, and that also was before the recognition that not all who are capable of pregnancy identify as women. Um, but it was the healthcare was delivered by lay health workers, often in a group setting, and except for the abortion, and that was the doctor who had a minimal role. So the idea was a kind of non-hierarchical approach to healthcare, kind of using healthcare to dismantle the patriarchy, I think was the intent, and to dismantle the male medical establishment. So that was kind of my foundation, really. And then I went to medical school, and then I worked with home birth midwives for 2 years, and that also exposed me to a different approach to healthcare, the midwifery model of care that really pays attention to the process and to the active participant of the laboring person. Um, and the healthcare provider's role is to be there, to be attentive, to offer support, and to intervene only when necessary. So I came from those two experiences, and then I began to offer abortion care. And Dr. Tiller had a very similar approach. In fact, when we first met, he talked about um, time, patience, and the baby will come. The woman's body is smarter than the doctor's. And that was like a really important tenet for him. Basically, the woman is smarter than the doctor,
Hmm.
and to pay attention to the process. And when I heard that, I said, "Oh, that's midwifery." And he offered me a job within 5 minutes. It was the shortest job interview I'd ever had in my life. So I brought that into the practice. Already I had those beliefs. And Dr. Tiller, I believe, also had a midwifery model of care where he really paid attention to the process, to the person who was at the clinic, to the pregnant person, and paying attention not just to the physical aspect of the care, but to the
Hmm.
emotional aspect, the emotional and spiritual aspect. And that was integral to the care that he offered. And I think I brought what I had my own experiences and then his. And then when he was assassinated in church in 2009, Dr. Susan Robinson and I were invited to start a third trimester practice at a clinic that was already existing in Albuquerque, New Mexico. That was Southwestern Women's Options. And so we brought many of the concepts that Dr. Tiller had, and then we expanded them. And so, for example, we always had midwives who were working at the clinic. And so we expanded the concept of the provision of care to expand to a midwifery model of care. And I think that's something people don't expect for third trimester abortion or abortion care in general. I don't think they expect to know to acknowledge the importance, and they don't expect it to be offered the emotional care as well as the physical care, the complete attention to the whole patient and not just to the physical aspect. I think that would be surprising to many people to learn about the kind of care that was offered with such love, compassion, and attention.
Hmm.
That was
Hmm.
a key part of the care that we offered.
I think so. I think you're right. I think a lot of people would be surprised about that. I think part of it is that we don't even see that level of care and compassion in a lot of pregnancy care clinics, right, in the US. So you're describing your experience, and I'm like, oh, that's so nice that you were able to combine these different elements. And I, coming up through some of the medical training that I got, it was very much it's either or, right? It's either a doctor or you do the midwife. There's never this bringing together of both the physical, the emotional, the mental, the spiritual. And so I think that that's important for people to know that it is something that is very much needed in abortion care, and is something that I think a lot of abortion providers really take to heart, and try to provide comprehensive care for people, that are undergoing these abortions.
Yeah, exactly. And actually, I think the kind of healthcare we delivered is the kind that everyone should have, not just for abortion care.
Right.
And it was not unusual for patients to tell us, both in Wichita and in Albuquerque, that this was the best healthcare that they had ever received. And
Wow.
they were surprised that it was at an abortion clinic. They too were surprised
Hmm. Hmm.
and heartened and happy.
Yeah. Yeah. Because it is. It's a very challenging time for the people, the patients that are going through this. So maybe you can tell us a little bit more about what are some of the circumstances that might lead a person to seek out a third trimester abortion.
Yeah. So I think when we hear about third trimester abortion care in the news, in the media, we tend to hear about fetal indication patients. And those are the ones I imagine your listeners are most attuned to, given your audience. Those are people who have learned during the pregnancy that the baby had a condition that would um, be serious enough to cause suffering, cause the child to suffer, either soon after birth or long term. So, for example, in my book, uh, Beyond Limits Stories of Third Trimester Abortion Care, I intentionally put that part, the stories of third trimester abortion care, in the title so people would understand what the book was about. I talk about a couple who found out, and these stories that I use in the book are composites of patients. Um, but it was a couple who found out that the baby had a heart condition. And for your audience, they probably know about it, a hypoplastic left heart syndrome. And that is a very, very serious condition that requires multiple surgeries over many years with a very uncertain outcome. Even the children who survive after the first and second surgery that take place over years, 1 in 10 will require a heart transplant. And these were people who were living, barely making it, were eking out a living, living in a rural area. And the idea of what that would, and they already had a child, what that would mean for the child to go through such intense intervention with an uncertain outcome, and what it would mean for their family who are living in a rural area, who didn't have resources. How could they manage? They made the decision to have an abortion. That's not something that they ever thought that they would do. And I think for fetal indications, I think that's a group especially that never contemplated that for this pregnancy.
Yeah, and that's what I would say for, again, my background is probably more so with those types of patients. It is always, I think, some of the more heartbreaking yet hopeful stories that I've just had a small piece in and talking and working with those patients. I always tell those patients, I was like, regardless of the decisions and what you decide to do, you are parenting right now, because right, that's what you're doing, is you're trying to figure out how to weigh all of these things and make the best decision for this this pregnancy that you can. And nobody ever wants to be in that position. I think that's the other thing too, is that sometimes it's easy to villainize, but the truth is it can happen to anyone.
Exactly, exactly. And what you said is exactly is what I would tell patients is you are being a parent by making the decision. You do not want your child to suffer. And that's what we do as parents. We protect our children. And this is a very difficult parenting decision that you're
Hmm.
making.
Hmm.
I do want to, sorry, I just want to point out that fetal, and I know we'll concentrate on the fetal indication
No, I
patients,
was
but
going to ask, I said, can you tell us some of the other indications that you may have seen as
yes,
well?
yeah,
Yeah.
yeah, because those are the ones that we tend not to hear about, and
Right.
I think
I
they
want to
are
make
as,
sure we talk about. Yeah. Hmm.
yeah, thank you so much, because I think that they are equally deserving of care, and that we would call maternal indications. And those are people who are ending the pregnancy perhaps because of a medical condition where continuing the pregnancy would be dangerous to their physical health. But it's also those who are ending the pregnancy because of difficult life circumstances. And there can be so many difficult circumstances where they make the same decision as the fetal indication patients. They believe that in this moment, in this pregnancy, that the best thing they can do as a parent, again, it's similar, is to end this pregnancy because they don't believe that that the life that they don't believe that they can offer their child a good life, and that's what they want, or they believe that the impact on them and their family would be too difficult to continue this pregnancy. And just as with fetal indications, there's so many different circumstances. Same with maternal indication patients.
Hmm. And I believe you have some of those stories as well in your book.
Yes, and again, they are composites, but they're all based on patients that I saw. And one was a woman who found out early in pregnancy that she was pregnant. She was in a very abusive situation, and it was difficult for her to access an abortion. And she faced many, many hurdles just even to leave the house, to be able to pay for the abortion. And there kept being roadblocks placed, um, which some were her home domestic violence situation, and some were state restrictions. This was even before Roe was overturned. By the time she finally was able to access an abortion, she was in the third trimester. That is not an unusual story. There was someone else I talked about who had a history of cancer, and she thought she was in remission. She was starting to have symptoms that she had thought was a recurrence of cancer. And it was a recurrence of cancer, but she was also pregnant.
Yeah.
And that highlights kind of delayed diagnosis of pregnancy where people don't realize that they're pregnant, which can include someone on birth control who's thinking, wait, I'm on birth control. How could I possibly be pregnant? So if my body's changing, maybe it's because I'm just eating too much or I'm not working out. So that's another situation. And then I also highlight a teenager because I think they are probably the most stigmatized and vilified of patients seeking a third trimester abortion. So I wanted to explain what was going on for a teenager, why they came in the third trimester, and they came with their this patient in particular came with her father, who initially the teenager thought, oh, my parents won't accept this, won't support my decision, but in fact they did, and she came to the clinic. And these are just three examples, and I use three examples of fetal indication patients. I The structure of the book is that I take three fetal indication patients, three maternal indication patients. We get to know them, we get to know their circumstances, and I take them through a week at the clinic so we can understand what's going on for them, but also understand the process at the clinic. Because
Hmm.
that's another thing that people don't understand. You know, they hear such stories about what goes on, and I thought I really want to demystify and destigmatize not just the patients who come, but the procedure itself. So I actually take people kind of day by day from the beginning when they first come to the clinic. It's a multiple day process to the last visit that they have at the clinic.
And I could say I really appreciated that as somebody who worked in a clinic where we were identifying typically fetal anomalies. Sometimes it was maternal conditions, and trying to answer questions that the patients were asking about, like, well, what is going to happen? What would it look like? And so I appreciated that you covered that. And I wondered if you could tell us more about what you did at the clinic or how you offered that informed consent so they understood what they were getting into, and what the emotional support looked like in the clinic, because you mentioned kind of that midwifery pull in, but how did you work with these patients that were making these types of heartbreaking decisions?
Yeah. So the care started with the first phone call. So someone would call, and they would speak to a phone counselor, and often they had multiple phone calls to the same counselor. And that speaking with a phone counselor was not just about what's the procedure, explaining the procedure, what it entailed, helping to figure out funding because that's a huge issue. Most states do not cover abortion care. New Mexico does, most don't. And um, most people are not able to pay the full fee and have to tap into abortion funds. And so it's helping patients navigate that. But another equally important part is listening to the patient's story and starting to offer support, because often that's the first time that that person has talked to someone about what's going on for them. And so sometimes these conversations are very long, but to me that's the start of the counseling process. When the patient ever start when the patient comes in, there's counseling, kind of three different ways, three different forms of counseling. One is individual with a counselor, and there again, they go through the process. They explain that this takes place over several days, that it's ultimately an induction delivery of a stillborn, and the body needs to be prepared for the induction, which takes place about 2 to 3 days later. Uh, it's it it's not that the person is in the clinic the entire time. They have procedures, and then they go back to their hotel, which is where most people stay. And then when their body is ready, labor is induced, and they deliver a stillborn. So that's explained. But the
Hmm.
counselor is also starting to, or rather, continuing to offer support. And then the patient meets with the doctor, and again, it's the same thing. So basically, the person has heard about the procedure multiple times. When people are stressed, it's hard to absorb things sometimes. And at that point, we sign consents. So I think that patients are well aware of the process and the procedure at that point. You mentioned the groups, and that's an important component of support for patients. We had two separate groups for fetal indication and maternal indication. And it was basically a support group for these patients because, again, often because of the stigma attached to abortion care in general, often this is not something they told many people. And to sit in a room with other people who know exactly what they're feeling, what's going on for them is incredibly empowering. And many times, well, not many times, sometimes patients would say, "Oh, I don't really like groups. I don't know if I want to do this." And I would say, why don't you just try? You don't have to say anything. You can just sit there. It might feel good to you just to sit in this room. And invariably, the person who said that they didn't want to talk talked at that meeting, because they were with people who understood them. And sometimes people even connected afterwards. I talk in the book about a maternal indication group where everyone went out for dinner afterwards. They form connections, they form bonds, and that's, I think, really an important part of the care that we offered.
I think so, because I think that was one thing that I noticed, and we had a support group for a while at the clinic that I was at. Although it was a bit of a challenge because it was in a large medical center, so it was hard sometimes to get people to come in person. But just that sense of isolation, I think, like you talked about, because it is so stigmatized, they felt like they couldn't really tell even close friends and family what was going on.
Yes, and what people are, it depends. I mean, it's very variable. For some, they do tell, and that tends to be the fetal indication patients who more often are more open, and yet often they don't tell anyone. I think it's really hard because of the stigma, and also they have to leave, they have to travel, they have to leave their state to access the care, and so that it's just such a stressful time getting the diagnosis, making a decision, arranging travel. It's not like you're going to talk to all your friends about this. You're just focused. Like, I need to get this care. And then coming home, I think, is how do I navigate this? What do I tell people when I
Right.
come home? I'm no longer pregnant. And I actually would talk in the group about a suggestion of what to tell patients. And what I would suggest, and this is for the fetal indication patients where people knew that they were pregnant, I said, keep it simple. You don't need to go into details. You don't owe anyone an explanation. And the simple sentence, the baby was sick. We went for testing. The baby didn't make it. And it's hard for me to talk about it right now. And those sentences are true and kind of ends the conversation. The baby was sick because if the baby wasn't sick, they wouldn't be here. We went for testing explains why they left. The baby didn't make it. True. It's hard for me to talk about it right now. Period.
Yep.
And that's something I always covered. That is one of the things in the group. And the group was mostly people talking to each other, but that's something I always covered.
I would say it's that anticipatory guidance because you know they're going to encounter some of those questions. So, kind of helping them go ahead and think a little bit maybe about how they want to handle
Exactly. And people had told me later that was very helpful to
it.
them. Yeah, exactly. To be prepared. The last thing you want, and I would talk about this, is like the last thing you want is you're at the grocery store and the checker asks you, "Oh, how's the baby?" And there you just burst out into tears because you weren't prepared. So being prepared, I think, is helpful.
Yeah, yeah. One of the things I wanted to touch on, because I feel like you hear about it probably in mainstream media, is about the safety of such procedures of third trimester abortion. And that's one of the areas where I feel like a lot of people have expressed concerns or why they don't believe that people should have them. How do you talk to people about the safety of the procedure?
Well, I just want to backtrack a little bit. I mean,
Hmm.
it's interesting, this focus, because when people talk about the safety of abortion care and they're implying that it's not safe, they forget to mention about the incredibly high maternal mortality rate in the United States
Yep.
for everyone, and especially for Black women. That doesn't seem to be part of the conversation, and that abortion is actually far, far safer than continuing the pregnancy and giving birth. So
Hmm.
that's my answer right there. It's like, let's talk about the maternal mortality rate in childbirth and compare it to abortion care.
Hmm.
And abortion is far safer.
Yeah, and I agree. I feel like when folks have concerns about it, I was like, well, we're not necessarily focusing on perhaps what we should focus on, which I don't think a lot of people are aware of the high maternal mortality rate here in the United States, which is shocking. I think
Yes.
for people when they find out about it. And I would say that that leads me really into my next question is thinking about the legal restrictions because we've talked about like how that prohibits people from potentially being able to have access in their states and having to travel. We talked about or mentioned the overturning of Roe v. Wade, and how's all of these legal impacts affecting third trimester abortion care in the United States?
Well, even before Roe was overturned, when it came to accessing third trimester abortion care, it felt like we were already in a post Roe world because
Right.
so many states banned uh, third trimester abortions. And so, as I mentioned earlier, most patients had to travel, had to leave their states. But now it's just a lot worse
Hmm.
because there are more restrictions and more bans. And so more patients are having to leave their state. And before, when it was 1 in 10 patients who had to leave their state to access care, now it's 1 in 5. And when you have to leave your state, it takes time. It takes time to make arrangements. It takes time to get funding. It takes time to arrange childcare. It takes time to get off
I
work.
was going to say
Not
it's even more expensive.
Yes, yes, and time marches on. I mean, the thing with pregnancy is it continues. So as all these delays just mean that people are coming for an abortion later and later, and there certainly will be people left behind, people who couldn't jump over all the hurdles, and they will have children that they we're not prepared to care for. And we know from the Turnaway study that looked at the outcome of pregnant people and their children who were turned away from an abortion clinic because they were too far along. We know the outcomes are dire. Those who were turned away compared to those who were able to access an abortion had a greater percentage of them were living in poverty, were tied to an abusive partner, and the children that they had were not doing as well. So abortion care is really life-saving.
And is third trimester abortion care even legal in the United States? Are there still some states where it is legal?
Yes, absolutely.
Okay.
Um, there are states that do not have viability bans. Most states in the United States that where it's still legal um, do have limits, but not all.
In your experience, after a patient and their family, they've undergone a third trimester abortion, how do they process their grief, or how do they find support after they leave the clinic?
Yeah, I think it's hard. I mean, I think of the clinic as this little bubble of support
Mm-hmm.
where everyone understands what they're going through. There's no judgment, there's only support. And then they leave, and it's hard. And I think you mentioned support groups after abortion care. I think some genetic counselors offer that or are aware of support groups, and I think that's tremendously helpful, but not everyone has access to that. Um, I certainly always talked about therapy and I recommended it, and um, I think that's something that could be better, and I would encourage genetic counselors to think about that when they send patients to a clinic, and I think they do. It's just that support groups are not always available. I think it's very helpful. I think because the recovery really from this is ongoing. It's not that, oh, you're no longer pregnant, you're fine. No, it's a process. It's a process of recovery.
And I know I've worked with some folks who have made it kind of, I would say, through that tunnel of grief, and they give talks, or they try to foster that community. So there's some folks that go through that and then are trying to figure out ways to offer support to the people currently undergoing.
Yeah,
Um,
which I think is so important and so wonderful. And it's some people offer support, some people become activists
mhm.
um, because they don't want other people to have to go through what they went through, having to leave their state, having to endure the stigma and the misunderstanding. Um, so this can be a transformative experience actually for some people.
Yeah, yeah, and I can say I've worked with a couple of patients that I still think about, who are adamant about not ending a pregnancy or not choosing termination. And as they adjust to the diagnosis, learned more about what was going on, they said, I never thought I would say this, but here I am. And, they were leaning towards, I think we're ending the pregnancy, the making those types of difficult parenting decisions.
Yeah. And I think sometimes we have stereotypes like, oh, someone who's deeply religious or someone who um, is very conservative um, wouldn't have an abortion.
Hmm.
But I have taken care of patients of all religions um, and all parties.
Yeah,
And many thought that they would never have an abortion. But then when faced with the particular circumstance that they're in, things change.
yeah, 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 yeah. Just don't know until you've been having to go through something like that. I know we've covered kind of a few different things through your career and through the book. Is there any one thing in particular that you would want listeners to take away from this conversation, or to walk away remembering?
Well, I think the most important thing for people to understand is that those who seek a third trimester abortion are the most desperate among us
Mhm.
because of the fetal diagnosis, because of their difficult life circumstances. And I think that it's important that they receive the care that those earlier in pregnancy receive. By that I mean have access and it be available to them, rather than thinking about limits, which is why I called the book Beyond Limits. I think it's
Mhm.
important that we think beyond that and we think about the people who need this care. And um, I would like people to be able to open their hearts to the most desperate, the most marginalized people who need this care, and understand the importance of it being available to people.
I think it's being able to have that compassion and that empathy, and to realize that are there is people on the other side as well, and they should be, again, treated with respect and dignity, because you don't know what you don't know, or what you haven't been
Exactly.
through. Hmm.
Yes. Yes. A patient's mother and the daughter was very religious Christian. Um, she was she was raped. Basically,
Mm-hmm.
she was given uh, her drink was spiked. Her non-alcoholic punch was spiked, and she was pregnant. And she came with her mother, and her mother said to me, "You don't know the story until you are the story." And that's true.
Yep.
But you don't necessarily have to live the stories. You can read about the stories and
Correct.
learn from them. You can learn from other people's experiences and understand their situation, because that person certainly never ever thought that she would be in an abortion clinic.
And I think that's why I would recommend folks to check out the book, because you do include those composite patient stories, so people really do get that firsthand account of what someone is going through. And it's not just clinical medical jargon or information. So I think the stories really are really impactful.
Yeah. On the contrary, I really wanted to avoid any medical jargon. I wanted to be accessible to everyone.
Yeah, yes, and I definitely think it is. So I just appreciate you taking the time to talk with us. Like I said, about the book and your career. So it's been wonderful to have you here.
Thank you so much.
For more information about this episode, visit allaccessdna.podbean.com, where you can also stream all episodes of the show. This link is also in the show notes for easy access. Any inquiries on the podcast can be sent to allaccessdna@gmail.com. Check out our Patreon at patreon.com/allaccessdna and consider donating to get bonus content, submit questions for our guests, and connect with other genetic curious individuals. Note that this podcast is for entertainment and education and is not intended to be a substitute for professional medical advice. Please consult your physician with any questions you may have regarding your health. Please rate and review the podcast on Apple, Spotify, or wherever you listen. This helps other people like you discover the show. All Access DNA is hosted, produced, and edited by Kate Wilson. The logo design is by Designs by NKJ. Thanks for listening, and join us next time.